Okay, great. So we'll obviously be talking about breast cancer and breast disease for the ABSITE, and the main focus is going to be on breast cancer because this is just where the main interest lies. I'll go through the most high-yield topics, and we'll discuss a little bit as we go along. Please feel free to chat in any questions that you might have. We'll first start with the risk factors and prevention, then go to workup of the breast mass, the treatment of breast cancer, and then the special situations that they love to ask about in the ABSITE. And then finally, we'll be talking about some benign or semi-benign diseases. So first of all, we have a few risk factors for breast cancer, and they're generally the non-modifiable ones and the modifiable ones. So we all know that females get more breast cancer than male patients, and that's a non-modifiable risk factor. Two biggest risk factors are being female and being older, so there's nothing really we can do. Then there's genetics, and we'll be talking about that in detail in a little bit because they love these questions on the ABSITE. A history of certain benign breast diseases puts you at a risk for future high breast cancer, and the ones to know are LCS and ADH, and we'll talk about those in a little bit as well. And endogenous hormones are also non-modifiable because you can't, influence how many hormones you make. But exogenous hormones are modifiable, so these are one of the big risk factors for elderly women, especially the perimenopausal ones who start to take hormones. Breastfeeding, as we all know, is protective for breast cancer. Usually the time that we require in order to be a protective agent is 12 months of breastfeeding. So when patients ask, I breastfed for 4 weeks, is that good enough? Most studies have looked at timelines of a year. Alcohol intake. Alcohol is a known risk factor for breast cancer, the less the better. Obesity, again, because fat cells can produce estrogen. And previous radiation exposure. And with that, we especially think about mantle cell radiation for patients who had lymphomas in their childhood. Those patients have an extremely high risk for breast cancer in the future and should also qualify for high-risk screening. What can you do to reduce your risk? This is especially aimed at patients who have an extremely higher risk for breast cancer in the future. You can increase their surveillance, which of course doesn't really reduce their risk of getting cancer, but increases the chance of you finding the cancer early enough to treat it properly. Chemo prevention is something that we've been doing now for a few years. Most commonly, this means a PO pill of tamoxifen, naloxone, or exemestane. And that reduces your future risk of developing breast cancer by about 50%. So that's a very good option for a lot of patients who don't want to have this. And especially in the and your risk for reducing breast cancer is reduced highest by a prophylactic mastectomy, which again reduces your risk by about 95%. Why is it not 100%? You might ask. This is because every time you do a mastectomy, there's few breast cells that are left over. So it's important to tell patients who do undergo prophylactic mastectomy to continue to perform exams of the skin that overlaid the breast in the past. Is that background noise gone for everybody? Can you guys hear properly again? Okay, good. All right, let's talk about BRCA 1 and 2 first. Those are the mutations we've known for the longest and the mutations that have most data for. We know that they're slightly different. They go along with breast and ovarian cancer as well as prostate and pancreatic cancer. And those are topics that they love on the ABSITE. So when you review these slides later, look at those ones especially. Depending on which study you look at, the overall lifetime risk for breast cancer for a BRCA1 mutation carrier is between 50 and 80%. And for BRCA2, it's 40 to 70%. So they're almost about equal. General population is 12%, as we all should be knowing. 1 in 8 women will get a breast cancer in their life. For ovarian cancer, it's 1 to 2% for the general population, and that is much increased for BRCA1 carriers, ranging from 24 to 40%, and for BRCA2 carriers, it's slightly lower, but still increased from 11 to 18%. One question that I've definitely seen in the past was the one about male breast cancer. It's obviously more common with BRCA2 carriers. So remember, BRCA2 is for male breast cancer more than BRCA1. However, their lifetime risk is still lower than that of a general population female patient. So the way they've asked this question is basically if male carriers of a BRCA2 mutation should have any kind of risk-reducing surgery or should get chemo prevention. And the answer to that is no, because their risk is still lower than that of a general population female. A person with a 12% lifetime risk does not undergo prophylactic surgery and does not get chemo prevention in clinics. So a patient who is a male BRCA2 carrier also does not require any kind of increased surveillance or any kind of chemo prevention. Should they be screened? Sure, that's reasonable. They should get mammograms. Why not? Their risk is about the same as that of a general female, and those get screened too. But no need for any kind of prophylactic surgery in these male patients. And you can, of course, also tell them to just do breast self-exams, especially if they don't have a big breast. That's kind of up to the individual. Prostate cancer, again, is higher for individuals with BRCA1 and 2 mutations, and that's probably more relevant for the male carriers than the breast cancer risk. And then pancreatic cancer, again, the risk is increased for BRCA1 and BRCA2 carriers, but to my knowledge, there's no good screening for pancreatic cancer. There's nothing to be done for that. However, when you get a cluster in a question where patient's family history is significant for pancreatic cancer, for prostate cancer, breast and or ovarian cancer, your ears should be ringing for BRCA1 or 2, even if it's not a breast question. Now, those prophylactic surgeries that I just touched upon, when should we be performing them? Not everyone with a BRCA1 or 2 mutation gets surgery. Not everyone wants it, and not everyone needs it. Oophorectomy is more pressing than mastectomy in general, simply because ovarian cancer has a much higher mortality and morbidity risk than breast cancer does. However, a lot of females want children and should not have oophorectomy until they're done with the childbearing. The risk of developing ovarian cancer goes up by decade, so it's pretty reasonable still in their 30s, but then goes up in their 40s. I know that this slide here is for breast cancer, but it's similar for ovarian cancer as well. So generally, these patients are recommended that after childbearing is complete to undergo oophorectomy, and that tends to be the time when mastectomy is also discussed. Now, there are some people who undergo mastectomy in their 20s, which is absolutely fine. It's a patient-driven decision. But there are BRCA carriers that never have a mastectomy and that never develop a breast cancer. And that is also fine as long as they commit to the high-risk screening. In general, oophorectomy is recommended first in the late 30s or early 40s of the patients, ideally at age 35, but life and child planning oftentimes doesn't go along with that. And then the mastectomy can either be done at the same session, can be done later, or can be done earlier. As you see here, their risk at age 40 for BRCA carriers between 10 and 20%, so about that of a general population person at age 70. So it's not necessary to be super, super aggressive and pushy with these mastectomies earlier, especially if the patient is enrolled in a high-risk screening program. These patients should only undergo oophorectomy, to my knowledge. Removing the cell-things doesn't really affect that, but I'm not sure how the GYNs handle it nowadays, if they just remove that along with it. Oophorectomy is the one that's in the guidelines. And now let's look at the testing guidelines that have been proposed, and that's actually been a question that's been highly debated recently. So the American Society of Breast Surgeons has published a statement saying that every single patient who has breast cancer should have genetic testing. And yeah, I'll get to the high-risk screening in a bit. Well, we'll talk about the testing first. This is a big topic. So the American Society of Breast Surgeons recommends that every single patient who has a breast cancer undergoes genetic testing because they've done a study where they looked at all the patients that didn't meet the other testing guidelines, and looked at the numbers of missed genetic mutations that they found, and those numbers were too high for them to be comfortable with not testing every single patient. Of course, that's not really feasible. So the guidelines still have the lower criteria in there, which are absolute musts. And then with the other patients, I think it's reasonable to discuss it. Oftentimes there's not enough testing availability, but the criteria below are absolute must-be testing criteria according to everyone. So patients who have a known mutation in their family, patients who develop breast cancer early on, less than 45 years of age, patients who have bilateral breast cancer, patients who have a triple negative cancer, less than 60, because those are associated with the BRCA1 mutation, patients who have Ashkenazi Jewish heritage at any age, patients who have ovarian cancer or a family history of ovarian cancer, any male breast cancer or any family history of male breast cancer, and then suspicious family cancer clusters, as I described. And there's other genetic mutations that we need to know from the ABSITE. In real life, these are not very common, but they're frequently tested. So Lymph syndrome has a higher breast cancer risk than the BRCA mutations. And it's much rarer, which is why it's not that commonly seen. But its risk is about 50 to 80% by age 45. So these patients should also have bilateral mastectomy. As we know, it's due to a P53 mutation, and it goes along with other cancers, among these sarcomas, leukemias, lymphomas, and brain tumors. Cowden's also has a higher lifetime risk, 20 to 50%, so slightly less than BRCA. This goes along with the PTM mutation and is associated with hamartomas, uterine cancer, thyroid disease, and microcephaly. And then the hereditary diffuse gastric cancer is also associated with a high risk of breast cancer, especially the lobular type, with about 40% lifetime risk. This goes along with the CDH1 mutation, as we all know, is also associated with gastric cancer. So it's important to, if you see a patient in the gastric cancer question on the ABSITE that have diffuse cancer, to be thinking about breast cancer risk. Poids-Jaeger syndrome also is associated with a high risk of breast cancer, about 32% by age 60. It's associated with an STK11 mutation and goes along with the classic hyperpigmentation of lips and oral mucosa and GI polyps. And then there's a few moderate penetrance genes that are pretty common. Those we see more frequently. CHEK2, ATM, and PALB2 all go along with about a 2 times increased risk of breast cancer. CHEK2 can go up to 40% lifetime risk. The PALB2, they might ask you what it is. It's a BRCA localizer gene that's mutated, and it goes along with a double of the increased lifetime risk. And now here's the high-risk screening slide. So basically, first of all, who should get high-risk screening? And this is anyone with a lifetime risk of greater than 20 to 25%. 20% is the cutoff for the insurance companies to cover your lifetime screening, your high-risk screening, but 25% is kind of the clinical cutoff, because it's really easy to get to 20% if you use these calculators. You can try it out for yourselves and just download the Tyra-Cuzick or the Klaus and the Gale score and play around with them to see. It's really, really easy to get to 20%. You basically just need one distant family member with breast cancer, which almost everyone has, and you're at a 20% lifetime risk. So of course, not everyone is getting high-risk screening who has that, but people with a higher number of family members who've had breast cancer in younger ages, even without a genetic mutation, may also qualify for lifetime risk screening. And generally, that's MRI screening done yearly at around age 25. Some people don't tolerate MRIs or can't get them because they're pregnant or they're claustrophobic. In this case, you can do mammogram or ultrasound alternatively, and those are usually done every 6 months, alternating. You should be discussing chemoprevention with these patients, and you should be discussing risk-reducing surgery with these patients. And again, the risk-reducing surgery can be done anytime, in their 20s, in their 30s, in their 50s, in their 60s. Anytime helps. Okay, I'm going to stop here quickly and see if anyone has any more questions about the genetic syndromes. So generally, the 6-month ultrasound mammogram is only patients who can't get the MRI, because the MRI is more sensitive than ultrasound mammogram, so you don't need to do all of those. MRI screening alone is sufficient. But in patients who don't want MRIs or can't get them, have a contraindication, you want to do the ultrasound mammogram alternating. All right, so a common question is the workup of a breast mass. This is as well for ABSITE as also for mock orals and oral wards where a patient presents with a palpable mass. For these patients, it's important to do your history and physical, and in the history, really see if there's anything that might warrant genetic testing, because that's a common pitfall in these questions where you don't genetically test and you do lumpectomy and then they actually do qualified for bilateral mastectomy, so don't forget to offer that. Furthermore, in your history, you want to ask for risk factors, pregnancies, age of menarche, basically duration of unopposed estrogen, and then do a physical exam. And the physical exam is both breasts and both axillae and cervical and supraclavicular lymph nodes. Imaging, generally we start with a mammogram or ultrasound, depending on the age of the patient. You can also add an MRI. We'll talk a little bit about that in a little bit. Biopsies can be done either palpation guided or ultrasound guided. The safest answer here though is imaging guided. But of course, if it's a giant fungating mass, oftentimes a punch biopsy will do. And don't forget the genetic testing. So talking about imaging in detail, as we all know, everyone should get screening mammograms starting at age 40. Again, debated, but for the purpose of the ABSITE, I would suggest age 40. You do a screening mammogram, and if you notice any abnormality on the screening mammogram, oftentimes that's followed with a diagnostic mammogram, where basically you do compression views or rotated views of the one breast, of the one lesion. Mammograms can also be used to help with a biopsy, and most often this is done for calcifications that can't be seen on ultrasound. Ultrasound-guided biopsy tends to be easier to do for the patient and also cheaper and more readily available, so we like to do everything ultrasound-guided if we can, but if that's impossible, a stereotactic biopsy will do, and oftentimes that's the calcification patient that gets to go to the mammogram stage. Ultrasound has the usual observer-dependent issue. It's really good for dense breasts. Some states, including the state of Connecticut, have actual laws where patients with very dense breasts have to get a reflex ultrasound. Other states don't do that, but remember, if you see a patient who has a dense mammogram, which is basically a mammogram that looks really, really white, and you can't really see anything, it might be a good idea to send that patient for ultrasound screening as well. And then you can do an ultrasound-guided biopsy. Some patients get MRIs. Most commonly, those are the ones who have a high lifetime risk. Those can get the screening ones, but you can also add in diagnostic MRIs, especially if there's multiple lesions that are seen. If you wonder about bilateral disease, if a patient is trying to figure out what the relation is from a mass to a scar to another lesion, if there's multiple biopsies already, MRIs can be very helpful. They're very sensitive and everything in the breast will show up, but they're not very specific and there's a high rate of false positives. Depending on which study you look at, only about 1 out of every 4 MRI biopsies will be positive for cancer. So these aren't great. MRIs can be used to perform biopsies as well, and those are the most expensive ways to biopsy and the most difficult ways to biopsy as well for the patients and for the radiologists. So whenever something can be seen on MRI and ultrasound, we prefer to do ultrasound. If it can be seen on MRI and mammogram, it's preferred to do it stereotactically. The MRI biopsy really should only be done for lesions that can absolutely not be seen on any other imaging modality. The BIRADS score is used to classify the appearance of a lesion on mammogram, and that's also one that's frequently tested. BIRADS scoring goes from 0 to 6, and a BIRADS score of 0 basically means an incomplete exam and additional images are warranted. So every single screening mammogram that comes back with a breast mass is a BIRADS 0 by definition. Don't be fooled, even if it's spiculated and calcified and whatnot, to give it any other BIRADS score if that question is asked. If it's a screening mammogram, still a BIRADS 0 until you've gotten additional images. And then you can go into the categorization. So a screening mammogram can either be a 0 or a 1, and usually everything else needs additional images, unless it's a known lesion that's been previously additionally imaged before. BIRADS 1 is a negative mammogram. This is basically a black breast where there's nothing else in it. BIRADS 2 is a mammogram that shows something, but it's obviously benign. That can be fat necrosis, that can be a fibroadenoma, that can be a previously biopsied lesion that we know what it is and that looks stable on imaging. That's a BIRADS 2. Those people get routine screening. BIRADS 3 means probably benign, 1 to 2% likelihood of this being cancerous, but it gets a short-term follow-up after 6 months, where you see if there's any change to it, and if there is, then you biopsy it then. BIRADS 4 is suspicious for malignancy, which gets a biopsy, and BIRADS 5 is highly suggestive of malignancy. This is your speculated lesion that has overlying skin thickness. And then BIRADS 6 is a known breast cancer that already has a clip in it and has been proven to be malignant from pathology. Those patients obviously need treatment planning. Let's talk about treatment. There's multiple modalities in breast cancer, which makes this topic so complex. Surgery is the mainstay of therapy, but there's also additional treatments, radiation therapy and medical therapy. And among those, the most important ones are chemotherapy and endocrine therapy. And then there's less commonly and most commonly used in clinical trials, immunotherapy and biologic targeted therapy. They don't love to ask about those in the absite, so I won't get too much into detail there. But breast cancer is treated very individually. For every breast cancer, it kind of depends on something. Radiation therapy will depend on if your nodes are positive, if you did a lumpectomy or mastectomy. Chemotherapy will depend on score of your oncotype, and hormonal therapy will obviously be dependent on whether or not your cancer is ERP positive or not. So the thing to remember out of this slide is that stage 4 cancer does not get any kind of surgery. Don't operate on a metastasized cancer. And don't offer chemotherapy, which is a systemic treatment, or DCIS. Don't do that. Everything else, surgery is what you do, which is good for us because we're surgeons. And everything else is a maybe. So radiation therapy will be a maybe for all of these stages. Chemotherapy, again, sometimes yes, sometimes no. Hormonal therapy will be dependent on the receptor status, and we'll talk a little bit more about this in detail. But remember from this slide, no surgery for stage 4 and no chemotherapy for non-invasive disease. You do not need to give systemic treatment for non-systemic disease. The point of surgical treatment is to remove all the tumor. This can be done either with a partial mastectomy, which is also called a lumpectomy, same thing. And you add on radiation to that to make the recurrence rate equal to that of mastectomy. In mastectomy, you have 3 options. You can do a simple mastectomy, which is basically you remove the breast and close the skin and the patient will be flat. You can do a skin-sparing mastectomy, which is generally the nipple goes and the skin is spared as much as possible to allow for an underlying tissue expander reconstruction or an autologous flat reconstruction. And you can do a nipple-sparing mastectomy for patients who are good candidates. Who is a good candidate for a nipple-sparing mastectomy? You want to remember that the nipple is part of the breast tissue, so obviously it should be someone where the tumor is far away from the nipple. And then from an oncologic point, you want to have someone where you don't see any kind of imaging that has calcifications reaching up to the nipple or anything that you think this might involve the tumor. And you can send intraoperative frozen or intraoperative nipple margins to check for that in the OR. But you also don't want to have a patient undergo a nipple-sparing mastectomy who's not a good candidate in that the nipple won't survive the surgery. The nipple is innervated from the underneath, not innervated, blood supplied from the breast tissue that's underneath. So if you remove all the blood supply and there's not enough blood flow coming from the skin surrounding it, the nipple will die, and you just subjected the patient to a longer surgery and you're back to a more challenging surgery for no reason. So generally, a good candidate for those are patients with smaller breasts. There are ways of getting larger breasted patients to have a nipple-sparing mastectomy, but I don't think those will be part of the ABSITE So don't worry about those. For purposes of the absite, the two criteria should be cancer far away from the nipple. 1 centimeter tends to be the classic cutoff, and patient is smaller breasted. They love to ask about margins. For invasive cancer, no tumor on ink is the accepted margin. For DCIS, on 2 millimeters. And for colloides tumor, the guidelines say 1 centimeter. That's also under debate at the moment, but for the purpose of the abscess, that's what I would answer. So just learn these by heart. And then the most complex surgical breast cancer topic is how to evaluate the lymph nodes. What's the point of the lymph node evaluation? It's to stage the patient appropriately to help make decisions about additional chemotherapy and radiation therapy, and or also to obtain local control, especially if there's gross disease in the axilla. Lymph nodes can be staged with a sentinel lymph node biopsy. You can also stage them with an axillary lymph node dissection, but why would you do the more extensive surgery if you don't have to? When you use what? This is the slide that's important here. So for a sentinel lymph node biopsy, where you remove only a few lymph nodes, the ones that drain, basically are the watchful lymph nodes that drain the breast first, this is a technique that can be used for the clinically negative axilla only. So remember, for the absite, anyone who has palpable disease before surgery gets an axillary node dissection because you don't want to leave any cancer behind. If there's evidence that there's cancer in the axilla, you do an axillary lymph node dissection. If they're clinically negative, you can do a sentinel lymph node biopsy. If your sentinel lymph node comes back negative, that's it. You don't need to do anything else to the axilla. Now, if it's positive, classically, you would then do an axillary node dissection and take out all the lymph nodes from the armpit. And this is where the 11 comes in, because people have asked, well, if there's only 1 or 2 positive lymph nodes and there's only minimal disease, and I give them all these additional treatment, including radiation, do I really need to go in for all these other lymph nodes? It's associated with a high morbidity. Patients get lymphedema. They get a lot of pain there, a lot of numbness in the axillary skin. Why do I need to do this? So they did the Z11 study, which I'm sure you've all heard of by now. But basically, if a patient meets the 11 criteria, they do not need to get a completion axillary node dissection. And those Z11 criteria were: they have a lumpectomy, they're clinically negative, it's a T1 or a T2 tumor, they're scheduled to have whole breast radiation afterwards. This is the first surgery that they're having. It's not a repeat cancer, and there's no extranodal extension. So in this case, if I have 1 or 2 positive lymph nodes, I don't need to do the axillary node dissection. How will they be asking this question? They will say, you had a patient, they had a lumpectomy, you get a positive lymph node back, what do you do? And then they will ask these separate criteria. So in one question stem, the patient will have partial breast radiation, lumpectomy, and otherwise they'll meet the criteria. They need an axillary node dissection or whole breast radiation. Partial breast radiation patients cannot be treated according to the 11 criteria. They will ask, the patient had a mastectomy, and they only have 1 positive lymph node and it's a single cell. Again, those were not included in the 11. You cannot apply the 11 criteria to mastectomy patients. They get an axillary node dissection. They will say the pathologist saw 1 node that had like gross disease outside of the node. Again, those were not included in the 11. They get an axillary node dissection. They will say the patient has a T3 tumor where half the breast is involved, but only 1 tiny lymph node with a single cell in it. Again, T3 is an exclusion criteria. They get an axillary node dissection. So these criteria you really need to know to answer those questions correctly. And then the next complicated thing that they might also ask about is the neoadjuvant chemotherapy question. So imagine a patient who presents to you with an advanced disease in the axilla. You feel the lymph nodes and you feel that this is involved. And you may even send them for a biopsy and get that lymph node biopsy and get it proven that it's cancer in there. So you send them for neoadjuvant chemotherapy, and after they completed that, they come back to you and their axilla is now completely normal. And you might even put an ultrasound probe in it and you don't see anything abnormal in there, maybe the clip from the previously biopsied lymph nodes, but nothing else. So now, technically, neoadjuvant chemotherapy patients weren't in B11. How do you treat them? Do you treat them according to the initial stage of the axilla, or do you treat them according to what the axilla presents now? And they've done 3 landmark trials to investigate that question and found out that a patient whose axilla is now negative after neoadjuvant chemotherapy that was positive before can have a sentinel lymph node biopsy as long as you get at least 3 sentinel lymph nodes. You use dual tracer, that means both technetium and a blue dye, and they weren't an N2 or a gross cancer in the axilla patient before. So if they converted from an N1 to N0, if you get 3 sentinel lymph nodes, if there's a clipped lymph node, you want to remove the clipped lymph node as well. And if you use both traces, your sentinel lymph node biopsy is good enough, meaning that you can trust its results. Any other situation, you only get 1 sentinel lymph node, you don't have technetium available, and you can only use blue dye in that situation, you need to do an axillary dissection, even if their axilla is node negative. So these are the remember them criteria, because that's a recent, I mean, not that recent, it's probably about 10 years old now, this data, but a relatively recent change in management of these patients, and they do ask that now on the ABSITE and in the boards as well. Questions about the slide? This is a very important one. Okay. To end off with this surgery part of the treatment, is always the reconstruction. You do want to reconstruct into patients who have a mastectomy. And you can also offer an oncoplastic approach where you do reduction or other plastic surgery things that the patient might want to have done at the time of surgery if you do a lumpectomy. But for breast reconstruction, for the purpose of the ABSITE, you can choose between tissue expander or direct to implant, and autologous reconstructions with DIEP flaps, tram flaps, LV flaps, and other flaps. They usually don't go too much into detail about the reconstruction part. Just offer to the patient if you're performing mastectomy. Remember that if you're doing lumpectomy, you can do other plastic surgery procedures at the same time, and that patients have these options and that they're basically equivalent. They will not go too much into detail about can you radiate them all. It's a hot debated topic among the plastic surgeons anyway. So let's talk about radiation. The best reconstruction alternative after radiation therapy? Yes, that's a good question. So there's a few plastic surgeons that do not want their autologous flaps radiated at all. But at Yale, where I trained, we radiated them all the time and patients did fine. So I'd say that's up to the plastic surgeon. If you already have radiated patient, say like they had a lumpectomy and radiation, and now after radiation get a second cancer and need reconstruction now, most people will prefer autologous tissue because you can just use the skin from the flap that you transfer and don't need to put an implant under a scarred down or tight breast skin that might not expand that well anymore. So I'm not a plastic surgeon, but what most plastic surgeons do is that they prefer autologous tissue reconstruction in a radiated chest patient, simply because the skin from the autologous flap can heal better than the skin that's already been radiated that now has to deal with the tension of the tissue expander. Radiation, the purpose of it is local control. Again, this is a local kind of treatment, and its purpose is to reduce the risk of recurrence. All lumpectomy patients should have radiation, except for selected elderly patients. I don't think that they'll ask you these criteria on the ABSITE. It's basically very old patients with very good tumors. But the correct answer is always you send them to the radiation oncologist, and they can discuss with the patient whether or not they can skip the radiation. For purpose of the ABSITE, I would radiate all lumpectomy patients. Who needs radiation after mastectomy? Patients who have positive lymph nodes, patients who have positive margins, patients who have large tumors, and patients who have locally advanced or inflammatory cancers. Now, who gets chemotherapy? Again, chemotherapy is systemic treatment. So you want to treat those patients who are at highest risk of metastasizing, as well as the patients who respond best to the chemotherapy. Who is that? Patients who have HER2-positive disease get chemotherapy because we have chemotherapy that targets HER2-positive cancers, and these patients have so many, their outcomes are so much better now that we have these therapies available. So everyone with HER2-positive disease, we want to give them Herceptin. Triple-negative patients, again, respond very well to chemotherapy, and almost all of them get chemotherapy. For the purpose of the ABSITE, I would always offer chemotherapy to a triple-negative patient. In real life, the tiniest triple-negative cancers might not get chemotherapy if they're like less than 5 millimeters in size, but for the purpose of the ABSITE, I would offer the chemo. And then patients with a high oncotype. What is an oncotype? Basically, it's a tool that helps you to decide if chemotherapy is worth it for cancers that traditionally don't respond well to chemotherapy, and that is ER-positive cancers, node-negative cancers. You might have a patient and you don't know will they benefit from chemotherapy. You can send off an oncotype to help you analyze the genomic subtype and help you make this decision. So again, oncotype, you don't need it for triple-negative patients because it's not even actually used in those cases. You don't need it for HER2-positive patients because they get chemotherapy anyway. You need it in those cases where you don't know. So people who have node-negative disease, people who have high oncotype. They love to ask whether or not neoadjuvant chemo is the same as adjuvant chemo. And it is the same when it comes to overall survival and safety, but it is better for patients who present with advanced disease because it can downstage both the axilla and the primary tumor. And it can facilitate breast conservation in a patient who desire that. So if you have a patient who presents with a large tumor and an advanced axilla, I personally would always send them to neoadjuvant chemotherapy because this way they might be able to avoid the morbidity of an axillary node dissection, and they may avoid a mastectomy as well. So you can easily do that. Furthermore, the oncologists like it because this way they can see how effective the treatment that they gave the patient was on the pathology afterwards. They can see if there was a complete response. I don't think oncotype includes Ki-67 That's a different one. Not everyone uses Ki-67. That's a proliferation marker. Like the people at Sloan never use them. Other people swear by it. I would not use Ki-67 for any kind of treatment decision. But some medical oncologists use it and find it helpful. I can't tell you why. This is a helpful slide because it just reminds you of the different molecular subtypes and the different things that breast cancers have and that we use for treatment making. So there's a subtype of luminal A and luminal B. For purpose of the ABSITE, luminal B is going to be ERP positive, HER2 negative. Luminal A is going to be ERP positive, HER2 negative. Luminal B is going to be triple positive. HER2 enriched is going to be ERP negative and HER2 positive, and basal is going to be triple negative. Chemotherapy you can offer for all of those, and again, the luminal A subtype is the one that will benefit from an oncotype because this will get chemotherapy anyway because it's HER2 positive, and the triple negatives will also get chemotherapy. Obviously, hormonal therapy only makes sense in patients who are ERP positive. Don't even bother offering that for these people. HER2-directed therapy similarly only makes sense in patients who have HER2 on their tumor cells, and then the novel therapies can be offered for all of the most commonly in the clinical trial. Endocrine therapy, what I've seen asked in the past was tamoxifen versus raloxifene versus aromatase inhibitors. Tamoxifen is the only one that's approved for the premenopausal patients, but again, it's not safe for pregnancy, so don't give it. Its side effects are DVT and PE, endometrial cancers, as well as cataracts. Raloxifene is for postmenopausal patients. The thrombotic event risk is lower and it decreases the fracture risk, so this might be good for patients with osteoporosis. However, most patients in the postmenopausal setting will be placed on aromatase inhibitors simply because it's best. And then immunotherapy, I don't think they'll ask you many details about it. The buzzwords that I would remember is that it targets the checkpoint proteins that block T-cell activity. So T-cells are blocked by these proteins from recognizing tumor cells and therefore attacking them. And the ones that are most commonly used are PD-1 and CTLA-4, if you see that those are the targets. So now let's spend a little bit of time to discuss the special situations, because I love talking about special situations in both ABSITE and the orals. Inflammatory carcinoma is one that is commonly asked. It's rare, but it's commonly asked. Generally, patients will present with a very red and inflamed breast, and you might see this peau d'orange, this orange skin type picture that basically just shows that the dermal lymphatics are blocked. And on pathology, you will see the dermal lymphatics involving tumor cells blocking the lymphatic flow. Inflammatory carcinoma gets treated one way all the time. Don't even bother overthinking this. It gets neoadjuvant chemotherapy, it gets a modified radical mastectomy, which is a mastectomy with a full axillary node dissection, and then it gets post-mastectomy radiation therapy. Every inflammatory cancer should be getting that. Don't overthink it. Don't offer sentinel lymph node biopsy. Don't offer skin-sparing mastectomy. Don't offer reconstruction. Nope. This is bad cancer that involves the skin. You want to resect as much as possible. This is maximum surgical treatment, which nowadays is a modified radical mastectomy without reconstruction. This does not get a sentinel lymph node biopsy. This does not get post-surgical chemotherapy. Nope. You give chemo first, you do the surgery then, and then you do post-mastectomy radiation. You can consider reconstruction down the line. You can give hormonal therapy as appropriate, depending on the pathology. You can use Herceptin if it's HER2 positive, that's all fine. But this basic treatment here never changes, at least as of now. And you want to just remove all the tumor, all the skin, all the lymph nodes, and all those. And the patients get neoadjuvant chemotherapy first, simply because it's easier to operate when this has calmed down and the skin has improved, because otherwise they also have bad wound healing complications after surgery because you might not be able to close that. So surgically, you want the neoadjuvant chemotherapy first, and then afterwards you're going to radiate that, and then if the patient survives this, you can offer them reconstruction down the line. But this is a very, very bad cancer. Don't forget that if you see this type of cancer before doing anything as well, you want to do a metastatic workup for these patients, because this is as advanced as can be. And you don't want to operate, obviously, if the patient is metastasized to the lung and bones. Pregnant patients, again, one that they love to ask. Pregnancy is a high hormonal state, so some people get cancer during pregnancy or after pregnancy. That's called pregnancy-associated cancer. About 1 in 3,000 pregnancies gets affected, so not super many, but enough. So these patients don't get the genetic testing because they're always going to be young because they're pregnant, right? And then you overall want to treat them similarly to your other patients with a few restrictions. So what are your surgical options? You can do lumpectomy, you can do mastectomy generally, but there's other things that you can't do. So you can't do radiation during the pregnancy, which most commonly means that you're going to offer the patient a mastectomy unless they're in their 3rd trimester, because then they can deliver and then get the radiation therapy after. So someone in their 3rd trimester might do well with a lumpectomy as long as they get the radiation after surgery and after delivery. Chemotherapy is an option during pregnancy, but not in the 1st trimester. In real life, that barely ever comes into play, because by the time that the workup and everything is done and the surgery has happened, they're already in the 2nd trimester. But if you happen to find a patient who in their 4th week, you can't do chemotherapy until they're in their 2nd trimester. You cannot do hormonal therapy during pregnancy either. That will happen after delivery. You can do a sentinel lymph node biopsy, but the blue dye is not approved. I once read that the reason why it's not approved is because it can cause congenital malformations in the infant. Apparently vascular atresia was the issue, like intestinal atresia. But you can use technetium, which is a little counterintuitive. You always think radiation is bad for pregnancy. Technetium has been looked at. It's safe. You can do a sentinel lymph node biopsy. So most commonly, the pregnant patient will need a mastectomy simply because timing won't allow for radiation therapy. But if they're towards the end of pregnancy, you can do a lumpectomy and they can have their radiation after. Chemotherapy they can have in their second and third trimester. So it is reasonable to say, oh, this patient is in her second trimester. If she really does not want to lose her breast, I'm going to do neoadjuvant chemotherapy, then I'm going to do the surgery in the third trimester or after delivery, depending on how long the chemotherapy will take, and then she's going to get radiation after. That's an option. You don't have that option if she's in her first trimester, then you have to start with surgery and do the mastectomy because she won't, she'll be pregnant long enough to allow for the radiation. You can discuss not continuing the pregnancy with the patient as well. But most of the time you don't really need to because you have enough treatment options. So remember, no chemo in the first trimester, no radiation therapy throughout the pregnancy, no blue dye, and then you use the tools that you have. So mastectomy most commonly will be the answer from a surgical perspective. And don't forget the genetic testing. Paget's disease is the scaly nipple lesion that they'll have the patient present with. It's often associated with underlying DCIS. It needs a biopsy. It needs a cancer workup. If the patient presents with that, what you're going to do is you're going to do your imaging first, then you're going to biopsy. Why would you not biopsy first and then send the patient for a mammogram? Basically, your biopsy could cause a hematoma, and then all you see on the mammogram is a hematoma. So do the mammogram first, do the ultrasound first, and then biopsy this, and biopsy whatever else you find on the imaging. And generally, these patients get a mastectomy and a sentinel lymph node biopsy, unless they don't qualify for a sentinel lymph node biopsy. They get the mastectomy because they will always lose the nipple. You can technically do a central quadrantectomy if you have an underlying mass right under the nipple, but the nipple needs to go and the tumor needs to go, and for most patients that need a mastectomy. Male breast cancer is about 1% of all breast cancers, and as we remember, affiliated with BRCA2. Don't forget to genetically test these patients if they're not checked already. They can present with bloody nipple discharge or a palpable mass, and they get the same treatment and they have the same survival chances associated with stage. Most commonly, they present in an advanced stage, but if they present in an early stage, it's the same. Yes, you can do a lumpectomy on a male breast cancer. You don't need to do a full mastectomy, even though most male patients will elect for that. But if they have a very large breast and they don't want the morbidity of a mastectomy, you can offer them a lumpectomy as long as the cancer is appropriate for that. That's fine. You do a sentinel lymph node biopsy just like you would with a female, and most of these patients won't get reconstruction, even though technically it's possible and feasible. Stage 4 cancer, remember, no surgery. Otherwise, you have all options: chemotherapy, endocrine therapy, targeted therapy, immunotherapy. You can consider palliative radiation, especially to the symptomatic metastatic sites. And if you see a patient, if they're advanced, if their axilla is positive, if they're complaining of vague headaches or vague back pain when you first see them for the initial cancer, order that metastatic workup. Metastatic workup generally is a bone scan and a CT scan of the chest, abdomen, and pelvis. And just don't forget to do it if the patient has anything that might push you towards that. There are no clinical scenarios where I would recommend resection in stage 4 unless it's for palliative reasons such as a large fungating mass that keeps bleeding. Then it might qualify, but remember that this always means a giant wound, a wound back for a long time, maybe need for a rotation flap. So it's very, very rare that this is appropriate. I've personally never seen it. I've been in cases where we've discussed it, but we always decided against it because of the associated morbidity with resecting stage 4, and don't go after these metastases. For the purpose of the ABSITE, you can do it. Okay, well, we're talking a little bit about benigner things. Nipple discharge most commonly is benign. There's physiologic and pathologic nipple discharge. The pathologic criteria for nipple discharge are spontaneous. Any patient who elicits nipple discharge is usually nothing bad. Just tell them to not squeeze their nipples. Pathologic nipple discharge tends to be bloody or clear. Physiologic nipple discharge is more like greenish or brownish. single duct and single side is always worse than multiple ducts and multiple sides. And if it's associated with a palpable mass, of course, that's also not great. Pathologic nipple discharge needs to be worked up. You start with an exam, again, both breasts, both axilla, then do your diagnostic mammogram of that breast. You can do a retroareolar ultrasound. You can add on an MRI and a ductogram if you think it's going to be helpful. Ducts can be excised with special surgery where you inject that duct with blue dye or where you insert a lacrimal probe, and you can perform that duct only. If you have trouble localizing that duct, you can do a retroareolar excision, where generally you just take all the ducts that live behind the nipple. Most commonly, nipple discharge is caused by intraductal papillomas, and these tend to be benign unless they're affiliated with atypia, but you do want to diagnose that. If you do a retroareolar excision, remember that these patients won't be able to breastfeed in the future, you should tell them that. Other benign entities that are on the SCORE curriculum, we'll just go through them really quickly, is atypical ductal hyperplasia. Anytime you see atypia, you want to excise it. Upgrade to cancer for those is usually quoted as 15 to 20%, and that means that the cancer lives next to that atypical ductal hyperplasia, not that atypical ductal hyperplasia turned into cancer. So excise these when you see them, and these are high-risk lesions. The patient's lifetime risk for future cancer is higher, even if it came back just as ADH after surgery, so you can discuss chemoprevention with these patients. LCIS, again, is a high-risk lesion. It's not an in situ cancer, as we previously thought. It needs excision only if it's not concordant with a lesion that they saw in the imaging. So if they see a mass on imaging and it comes back out the biopsy as LCIS, that's not concordant. LCIS doesn't form masses, likely they've missed the area that they saw on imaging. So you want to have them localize that lesion and then go back for surgical excision. If LCIS is all you see, you want to discuss high-risk screening and chemoprevention for these patients. Fat necrosis is common, especially in patients that had a lot of plastic surgery, reductions, autologous flaps. It can feel hard and nodular-like. Radial scars is something that I would encourage you to Google just so you see what it looks like on the mammogram. Again, benign. We're debating whether or not all of these should come out or whether they should only come out with atypia. Probably won't hurt if you excise them for the purpose of the ABSITE. Pleomorphic LCIS treated like DCIS. Yeah, that's a good question. Pleomorphic LCIS is more aggressive, so that I would take out and that I would treat like DCIS. Last topic, we'll be talking about mastitis. This is one that that's actually very, very common. And is most commonly associated with lactation. So the way this works in people is they lactate, they get a clogged duct because they empty their breasts inadequately, or they only nurse from the one side and they forget to feed the other side, or they have a pump that doesn't work. But they get a clogged duct, that duct doesn't drain. Similar to the way appendicitis happens, you then get mastitis, lymphatic drainage, venous drainage, and the whole breast turns red, and then you have to evaluate if this is inflammatory cancer, this mastitis. Obviously, in a breastfeeding patient, mastitis is a more likely diagnosis. You want to give them antibiotics and see if it improves, and if it doesn't improve, you need to think about inflammatory cancer and do that workup. Mastitis can be associated with abscesses. Obviously, patients can have abscesses that don't have mastitis, but mastitis often leads to an abscess. And then that abscess can turn into a galactocele if it gets access to the milk system. So then you have milk and pus in that abscess, which is not great to treat. You can aspirate it, you can IND it. If you IND it, you then risk creating a milk fistula where basically milk will leak out of that hole in the breast for a while. Not a fun thing to treat. All the time you think that these are the most common things for mastitis and lactation, but breast cancer is always there. And remember that it's pregnancy associated, and lactating people who are just pregnant, so it's possible they developed a cancer during pregnancy and they can have it. So you need to take any kind of complaint serious in a lactating patient and work it up appropriately. There's a lot of misinformation out there about whether or not these patients can have radiology, but they can. Yes, a breast full of milk is not great to image on a mammogram, but if you tell the patients to empty their breast either via pumping or breastfeeding like before the imaging, you will still be able to see most lesions. They can also have an MRI, they can also have an ultrasound. They can continue breastfeeding basically until they have chemotherapy. There's no real contraindication to breastfeeding for anything until they start chemo. The surgical risk of a milk fistula is small. You can do a lumpectomy in a breastfeeding patient. You can do an IND in a patient who's breastfeeding or lactating and has any kind of complications, but you overall generally want to avoid incisions as much as possible. You want to make them small. You don't want to make them in the perioareolar region, because if you do, then the patient can't put a pump on their breast afterwards. And then if you've incised the breast and then you have a lot of milk blockage in that breast, you might cause additional problems such as iatrogenic galactoses and iatrogenic mastitis. So don't do that. And then in the lactating patients, you want to avoid only a few medications. Codeine's not safe. Chemotherapy is not safe. Some rare antibiotics aren't safe, but most medications are actually breastfeeding compatible. So don't overreact there either. Again, milk fistula in these patients is a very small risk, but it happens. If it happens, you want to encourage the patient to drain the breast via the nipple, whichever way possible. A lot of breastfeeding, a lot of additional pumping, so that the milk will go the path of least resistance and not go through the wound. But it's a pain to manage these. Don't forget, again, the genetic testing if you diagnose a patient cancer in these patients. Don't forget mastitis versus inflammatory cancer. And don't forget that imaging is okay and is necessary to do in these patients. And I think that's all I had for you, and it's 10:59, but if you have any questions now, please go ahead.
Thank you, Dr. Friedrich. That was an excellent overview of breast surgery. Anybody have any questions? You can put them in the chat. Okay.